Hi, everybody. It's just a little bit after 9, so we're going to get started on our webinar. So I want to welcome you to the New York City Community Health Center Geriatrics Education Project. It's a joint initiative between the Community Healthcare Association of New York State, CHCANES, and the American Geriatrics Society, AGS. My name is Amy Segelk. I'm on the AGS staff, and today's webinar is on the functional assessment of the older adults that you see as patients in your clinics. Before we start the presentation, I just want to give you a few housekeeping notes. The faculty members are going to present for about 40 minutes. The last part of the presentation will be specific case studies, and we are going to open up for questions about the cases after each case is presented. And after the cases are presented, we'll have a general Q&A session. So you can type your questions into the Q&A chat window on the right side of your screen at any point. But again, faculty will answer questions at the end of each case and at the end of the presentation. If you have any technical questions or difficulties, you can send me a message in the chat window at any point. Just to let you know, you're eligible to receive 1 hour of AMA Category 1 Continuing Medical Education credit for participation in the webinar. In order to receive the credit, you must complete the post-test after the webinar is concluded. I will review the details of that after the Q&A session. And so now I'd like to introduce our speakers, Dr. Thomas Gill and Dr. Veronica Rivera. Dr. Gill is Professor of Medicine, Epidemiology, and Investigative Medicine and the Humana Foundation Professor of Geriatric Medicine at Yale University, and he's a leading authority on the epidemiology and prevention of disability among older persons. Dr. Rivera is an assistant professor at the Icahn School of Medicine at Mount Sinai in both the Brookdale Department of Geriatrics and Palliative Medicine and the Department of Family Medicine and Community Health. She practices outpatient medicine at the Coffey Geriatrics practice at Mount Sinai and at the Family Health Center of Harlem with a focus on improving geriatric care for underserved patients. Also to let you know, many of the assessment instruments we'll be discussing today are in the appendices of the book entitled Geriatrics at Your Fingertips that you should have received in the mail a few weeks ago. A copy of the Montreal Cognitive Assessment Test, or MOCA, was also emailed you with the registration information. So if you didn't receive copies of the materials, please let your CHCANES staff contact know and we'll follow up. So now I'm going to turn the webinar over to Dr. Gill.
Thank you very much, Amy. Welcome, everyone. Good morning. Just to indicate that neither Veronica or myself have any disclosures of relevance to today's session. The two of us have split up the content that we're going to present. First, just want to provide a broad overview and highlight our 3 learning objectives as noted on this slide. First, to understand and describe how to assess the functional ability of the older adult. Second, to apply the key elements of a rapid screen. And third, to define strategies to enhance communication with your older patients. And we're going to be covering the topics listed on this slide, starting first with the principles of a geriatric assessment, followed by communication strategies, physical assessment, cognitive assessment, psychological assessment, social assessment, a few words on quality of life, and ending with acute functional decline. So it's a fairly broad, talk, and we'll cover some areas in more details than others. So to start with the principles of geriatric assessment, we've broken them down into these domains. First, the goal is we need to be mindful of is to promote wellness and independence, which is usually the primary objective of our older patients. The focus, unlike other aspects of medical care, focuses intently on function, and there's a preference for objective or performance-based function, particularly related to gait, balance, and transfers. Mobility, as you'll hear, is really one of the most important aspects of a general geriatric assessment. The scope will include physical, cognitive, psychological, and social domains. The approach is multidisciplinary. Physicians need to partner with nurses and other clinical disciplines to provide the best care, focusing on promoting function in older persons. There needs to be an efficient mechanism to do so. So the strategy will recommend rapid screens followed by further assessment in targeted areas based on the results of the screen. And our marker of success is to maintain or improve quality of life and function. So I'm going to go through a series of slides for the rapid screening, and that will lead to some of our later slides that talk about the domains of function. First, for functional status, a simple screen is to determine whether your patient, because of a health or physical problem, needs help to accomplish one of these 5 activities, ranging from shopping, light housework, walking across a room, taking a bath or shower, or managing household finances. A yes response to any of those questions would warrant further evaluation more broadly within the functional domain. A very simple test that can be completed in just about a minute in almost any clinic setting is the time get up and go, in which an older person's sitting in a chair. They arise, they walk 10 feet forward, they turn around, and they sit back in that chair. If it takes longer than 20 seconds, then that's an indicator of significant mobility problems, and further evaluation would be noted. And this test can be administered by almost any office staff. It's quite a robust measure. For nutrition, a recommendation is to assess whether there's been unintentional weight loss of more than 5% in the prior 6 months. There's also concern if the BMI, which is weight divided by height squared in kilometers over meter square, if that's less than 20. And that's typically apparent on exam in someone who's quite thin. Vision, another objective mechanism for screening. If someone's unable to read a newspaper headline and sentence while reading with their corrective lenses, you would want to go on and test each eye with their Snellen chart, and an abnormal result would be unable to read greater than 20/40. And as you know, there's an array of visual disorders in older persons, from cataracts to glaucoma to macular degeneration, most of which will respond to therapy. Hearing, the screening is to acknowledge whether there's hearing loss when questioned. So you can just ask your patient whether they've have some hearing problems, or if they're unable to perceive a letter-number combination whispered at a distance of 2 feet. This is the whisper test that you've probably heard about before, and you can do that in each ear. Cognitive function, the best simple screen is a 3-item recall. And if the patient's unable to remember all 3 items after a minute, that's an abnormal response and would warrant further consideration. And for depression, a single question has high sensitivity. Do you often feel sad or depressed? A yes response would warrant further consideration of depression. I'll turn this over to Veronica for the next few slides.
Hi, everyone. So for the next few slides, we're just going to talk a little bit about some communication strategies to remember. These are things you already know and are doing in your practice every day. Definitely make sure, as you're working with your geriatric patients, to introduce yourself and address the patient by their last name, especially with some of our diverse cultures. Our elderly population is looking for expecting to be addressed with respect. So I would highlight addressing patients by their last name as a default. Make sure to face the patient directly, sit at eye level, and speak slowly. And then also make sure to have open-ended questions. Couple things to remember. As you're working with patients who are older, definitely hearing deficits can be very common. So you may want to ask about their hearing loss, as we'll talk about in the talk, and then also raise your voice volume accordingly. It might be nice if your clinic has available a pocket talker. Those are sometimes helpful to help communicate with patients who have significant hearing loss. And if you have those available, those are quite handy, especially if patients don't have their hearing aids on them. Also, if necessary, when you're communicating via, for example, in your post-clinic discharge instructions, you want to make sure the print is large so that they're able to understand if they have vision issues. And then also, of course, you want to make sure to allow for ample time for your patients to answer. Sometimes it takes a little bit longer for them to communicate. And I'll hand it back to Tom.
Thank you. So based on the screen that I reviewed a few minutes ago, that may lead you to a more complete evaluation in the specific domains in the presence of a positive screen. So a complete physical assessment includes these 5 domains: functional status, nutrition, vision, hearing, and cognition. In a busy practice, it's just not possible to assess each of these in a single visit. So the strategy that is often recommended is to include one or more of these within a visit, and over the course of several months, you would get through the complete geriatric assessment. So here are some tools to assess functional status. The most basic activities of daily living include walking, bathing, dressing, transferring, toileting, feeding, and grooming. These are the tasks that are essential to maintaining independent living in the community. If you're unable to carry out these tasks, you're going to need to have a caregiver in the home. Instrumental activities of daily living include tasks such as using the telephone, preparing meals, managing finances, taking medications, doing laundry, doing housework, shopping, managing transportation. These aren't all essential activities like the basic ADLs, but many of them are quite important to maintaining quality of life and function among our older patients. And these tend to become affected earlier than the basic activities of daily living, and so may herald the onset of functional decline in your aging patient. I mentioned earlier the timed get up and go. There's also, aside from the time, which I mentioned earlier was 20 seconds, just watching your older patient get out of a chair, walk down the hall, and turn and come back is probably better than almost any neurologic exam in terms of muscle strength and cranial nerves. Gait and balance requires a lot of processing in the brain, and also an assessment of peripheral neurologic, peripheral nerves. So it's really a nice integrative test that provides a wealth of information. You can observe your patient doing that with or without their assistive device, and it often can be informative in making decisions about an assisted device. The gait speed component of the timed get up and go is probably the strongest single predictor of almost any relevant outcome in older persons, particularly functional outcomes. And gait speeds up below 0.6 meters per second raise concerns. About 0.8 allows someone to be independent in the community. About 1 meter per second allows someone to be able to cross stoplights and things of that nature. More broadly is a concept called life space, which is a more global measure of mobility, meaning how big or small is their physical world? Are they confined to a single room in their home, meaning that they can't get up the stairs to the bathroom or the bedroom? They're stranded on the first floor, or maybe they can't get down to the cellar. Perhaps they can get in and out of the house just to their car so they can go to the doctor's appointment, but otherwise, their life space is constricted. Or, do they have much broader capabilities in which they're driving and taking public transportation and going shopping and things of that nature. So that's a concept that's getting a lot of credence these days. In terms of nutritional status, I mentioned earlier visual inspection in terms of temporal wasting and skin folds and things of that nature can be helpful, but repeated measurements of weight and the ability to calculate BMI based on weight and one's height will allow you then to look at changes in BMI, and if someone crosses this threshold of 20 kilometers per meter square. And with electronic medical records in many facilities now, this information can be easily entered and monitored. Unintentional weight loss of more than 5 pounds in 6 months also raises concerns. And poor nutrition is kind of an integrative measure that could reflect, underlying medical illness, depression, cognitive loss of cognitive abilities, functional losses, financial hardship, and it would be necessary to explore each of these areas since they may contribute to the weight loss. I mentioned earlier about the different disorders that are highly prevalent in this population. During the course of your conversation, you can be asking an assessment of the functional abilities, ask about driving, watching television, reading. Each of these tasks require visual capabilities. I mentioned earlier about the performance-based screening and also the use of a Snellen and chart or Jagger card. Hearing loss becomes increasingly prevalent with age, and strong evidence linking hearing loss to depression and social withdrawal. It's not uncommon for hearing loss to be due, at least in part, to impaction of wax or cerumen, and you'd want to quickly evaluate for that. Hearing loss, age-related hearing loss is usually bilateral and in the high-frequency range, and your patients may have more difficulty interacting with women who have higher voices typically than men. And we should have a low threshold for referral for formal audiometry testing based on complaints of hearing loss or on that whisper test that I mentioned earlier. I'll turn this over at this point to Veronica, who will cover the cognitive domain.
So why screen for cognitive loss? This is a really important topic. It's very common. We're going to talk a little bit about the prevalence, but also important to know that most people with dementia will not be complaining of memory loss to you. You can, of course, ask about memory complaints, but often they will deny any memory difficulty. Cognitively impaired older adults are at increased risk for accidents, delirium, medical non-adherence, and disability. So the prevalence is pretty significant. Around the age of 65, about 5 to 10% of your patients will have some cognitive impairment, and that doubles every 5 years. So when you reach the age of between 80 and 90, it's almost 50% of the patients who you will be seeing in clinic will have some cognitive impairment. So really important to keep this high on your list of things to assess for. how to assess for it can also be challenging, especially with a diverse population that you often encounter in the FQHC. One thing I will highlight before we talk about the cognitive assessments is I do find it's very helpful to always ask about the level of education. And then, of course, in addition to level of education, your patient's language is going to be a factor, and then also hearing loss and vision loss will impair your ability to perform some of these cognitive assessments. So definitely recognize that those are some barriers on doing cognitive assessments on your patients. That being said, these are some of the cognitive assessment tools that we have. So first, remember, we're always looking for short-term memory loss and impairment in other cognitive domains. So one simple way to assess for short-term memory loss is to do a simple 3-item recall after 1 minute. We also have the Folstein's Mini Mental State Exam, the MMSE, which most people are very familiar with. It's actually proprietary, but it's a test that most people are still using. It's scored out of 30. I'm also going to highlight in a couple slides the MoCA, or the Montreal Cognitive Assessment. And this is not copyrighted, and it's also available online in multiple languages. So it's nice if you're working with a diverse population with different languages. And then also there's the SLUMS, or the St. Louis University Mental Status Exam. These are other validated tools that you can use to assess for cognition. And then finally, a couple tests for executive function is a clock drawing test, and then listing 4-legged animals. You can also just do some a simple animal naming test in a minute, asking how many animals they can name. And about normal is about 18 animals a minute. So if they're less than 12, that's abnormal. So real briefly, I wanted to highlight two that I use significantly in my own practice, the MiniCog, which incorporates both the 3-word recall and the clock draw together. So I start by giving them 3 words. You can pick any 3 words: ball, flag, tree, apple, table, penny, anything that you like, and then ask them to draw a clock with all the numbers and the time. 10 minutes past 11 is often one that's frequently used. And then you can score. If the score is 3 or higher, then that's a reassuring test. And if it's less than 3, it would be further assessment is warranted. Like I said, you can go to the MMSE, but also the MoCA is a little bit more sensitive for picking up cognitive impairment. It's a little bit more of a challenging test, especially if your patient has low literacy level, or so it may be more challenging, but this is a copy of it. It's available online at mocatest.org, as well as the instructions. Okay, I'll hand it back to Tom.
Thank you, Veronica. Within the psychological realm, the epidemiology suggests that the prevalence of major depression is relatively low at only 1 to 2%. But there's kind of this iceberg right underneath the surface of, in terms of subclinical depression, which is quite common. And often can contribute to many of the geriatric syndromes that become increasingly common with age. I mentioned earlier the best single question to assess about depressive symptoms is, do you often feel sad or depressed? A yes response might lead you to do the geriatric depression screen, which is the short version is 15 items, so a series of yes/no questions, or 2 questions from the PHQ. And based on the responses there, you might pursue further evaluation for significant depressive symptoms, or perhaps even depression. We should be mindful that depression in older persons may present atypically and may include symptoms of anxiety, and that this population is experiencing a lot of losses and bereavement. And the recommendations now are that bereavement should be treated earlier than we had previously thought. So we should be mindful of this in our aging population. In the social domain, it's quite broad, and particularly, depending on your clinic environment, we need to be mindful of different ethnicities and diversity of spiritual and cultural backgrounds, and mindful that these have important influences on the provision and acceptance of our medical recommendations. It's critical to understand our patient support systems, and when care is needed, who's available to provide that care. Often we're treating not just the patient, our older patient, but also their caregiver, and we need to encourage them to be mindful of their own health, because if they don't take care of themselves, they're not going to be in position to take care of their, of the patient. Many aspects of medical care are going to be contingent on one's economic well-being, whether it's co-payment for medical care or out-of-pocket costs for medications, whether they're over-the-counter or not, and many of our patients may not be filling prescriptions for this reason. We can't do an assessment ourselves of the home environment within a clinic setting, other than for home care programs, but we can inquire about potential hazards in the home, particularly stairs, and if there are any concerns, have a home safety evaluation ordered, which Medicare will typically pay for. Elder mistreatment is usually under-recognized, and this includes neglect. And in fact, neglect is probably more common than physical abuse, although emotional abuse is not uncommon. And we just need to be sensitive to this possibility, and if there's any concern, have a low threshold for getting protective services involved. And we want to make sure that we have an opportunity to talk to our older patients about their goals of care in the context of advanced directives. So when or if the time comes and our patients become acutely ill, we know in advance how they would want to be managed in terms of the level of aggressiveness of care. A few other areas that would round out the social assessment include substance abuse, whether that's alcohol or other illicit drugs. And also, we can't assume that our older population is not sexually active. In fact, the majority are, and at risk for sexually transmitted infections, which, again, are under-recognized because the supposition is that our older patients are not sexually active. Most broadly is this concept of quality of life, which is an integrative concept that includes physical, cognitive, psychological, and social function, all kind of tied up together. There's an instrument called the Short Form 36 Health Survey that, based on a series of questions, will provide a score from 0 to 100 to allow us to determine where they're at in that spectrum of quality of life, with 100 being a perfect score and 0 being the worst possible score, and it covers the domains that I've just listed. I mentioned earlier about ascertaining our patient preferences regarding medical care and goals of care, and this can be very informative in when we're considering prescribing medications, because sometimes the treatment is worse, or the side effects from the treatment are worse than the condition that we're trying to manage. And just be sensitive to the role of culture and ethnicity on understanding of health and illness. Lastly, acute functional decline in this population is usually precipitated by an illness or injury, and it could be a significant event such as a hip fracture or a stroke or heart failure, pneumonia leading to hospitalization. And I'm sure we're all aware of the substantial decline that can occur in a hospital setting with one of these disorders. But among older persons who are physically and or cognitively frail, who are the most vulnerable, about a third of new disability, meaning the inability to carry out basic activities of daily living without personal assistance, occurs in the absence of any discernible illness or injury. It represents a natural progression of the underlying impairments in cognition and physical abilities. But contrary to kind of conventional wisdom, most of our older persons will recover after a major disabling event over the course of 6 months. But they're at high risk thereafter for disability. They become increasingly vulnerable, and it's kind of part of this downward cycle that's often difficult to break. I'll turn this back over to Veronica.
Thank you. So now that we've heard about the different aspects and parts of the geriatric assessment, how are you able to implement these at your FQHC? We recognize that you're working in overwhelming, sometimes busy practices, and you're dealing with patients who have multiple medical problems, polypharmacy, et cetera, et cetera. So often overwhelming to feel like you have time to do some of these other assessments. So one tip is to think about using your team. As Tom alluded to before, some of these rapid screens can be done by other members of your team, including medical assistants and nurses. For example, at my geriatrics practice at Mount Sinai, the medical assistants, when they do the vitals and triage of the patient, they do a quick question and ask about falls in the last month or fear of falling. They also administer the PHQ-2 to screen for depression. You can also even think about training your staff to administer a test like the mini-cog to assess for cognitive impairment. So, and as well as the timed up and go. So you can even think about creating a geriatric assessment template and train your medical assistant and nurse how to administer that. So something to think about. And then also thinking about using your electronic medical record at your practice and using tools within the system to help you administer some of these. So for example, we have Epic, and I'm not sure which electronic system you have. In a dot phrase, we have here the geriatric review of systems, and it reminds us to ask about weight changes, depression, memory loss, falls, hearing loss, vision loss, and incontinence. So a way you could think about incorporating that into your electronic record. Similarly, in our physical exam, we have a template for the timed up and go, mini-cog, and a couple other balance tests as well that are incorporated, something to think about. As well as once you get a positive screen, what to do with that. You can sometimes have templates or smart sets to help providers make the appropriate referrals. And just to review, this is the rapid screen that we went through today, the functional status, asking about ADLs and IADLs, mobility, doing the time to get up and go, nutrition, asking about weight loss. Also, you can objectively look at BMI, vision, asking about their ability to read a newspaper headline, and sentence while wearing corrective lenses. Hearing, the whisper test or asking about hearing loss. Cognitive function, the 3-item recall or the mini-cog. And then finally, depression. Okay, so just a couple tips. Remember not to get overwhelmed. You can do these assessments over time, and your patients will definitely be coming back, which is the beauty of primary care. And in summary, the focus of the geriatric assessment is on function. Successful assessment promotes wellness and independence. And strategies that enhance communication with older patients should be used. And the comprehensive assessment includes physical, cognitive, psychological, and social aspects of health. So as Amy mentioned, we're going to illustrate some of these assessments with a few cases. As Amy mentioned in the beginning, I actually am also a family medicine doctor and geriatrician, and I practice at a FQHC in East Harlem. So I am familiar with how difficult it can be to deal with very complicated older adults in the FQHC setting. So I wanted to illustrate with a few simple cases how the geriatric assessments were applied and prioritized actually differently for the following 3 cases. And as we go through the cases, after each case, if you have questions, feel free to type them in, and I'll try to address them after each case. And then also we'll have time at the end for some general questions and answers. So in terms of how I think about how to approach a geriatric assessment, one other thing to remember is to always, for me, I prioritize getting a good sense of their functional status and trying to assess what's going to be most harmful to them. So, for example, if falls or dementia is a problem, I'll prioritize doing those geriatric assessments. So let's talk about the first case, Mr. JV, who is an 88-year-old Latino male with diabetes and hearing loss, pretty significant hearing loss, so that definitely impacted our communication. His chief complaint was that his primary care physician had retired and he wanted to transfer care. He has a history of diabetes, anxiety, and hyperlipidemia, and those are his medications, including metformin, statin, and a benzodiazepine alprazolam, which as a geriatrician I was very concerned about. So I first met him in the visit. We're assessing his chronic conditions, including his diabetes. His A1C was 6.4, and which, from a polypharmacy standpoint, came up, does he need to be on medications? So that was something that I was concerned about, as well as his anxiety. So part of the first visit, I was definitely at risk or concerned about his risk for falling. He denied any falls. He was ambulating with a cane. He actually came to clinic by himself, which showed me that his functional status was pretty good. He came without assistance, had no difficulty finding a new clinic, navigating the system there, so I could tell that overall in general he was functionally doing well. And then also he had, as I mentioned, had significant hearing loss and wore corrective lenses for his vision. So a lot of the visit was focused on his anxiety. We talked about decreasing his Xanax to twice a day, and I saw him back a few weeks later just to see him. Again, the second visit, we didn't get to do too much. I can't remember if the clinic was particularly busy that day. We worked on changing some of his medications, including taking him off, decreasing his metformin, and adding a medication for his constipation. I had him back in February, and I had more time to do some of the geriatrics assessment that I wasn't able to do before. I spent a little bit more time focusing on his social history. I found out that him and his wife live alone. His wife is quite ill, has been hospitalized a lot. He's pretty independent on his ADLs and IADLs. However, his wife was in charge of the finances, so that was something to keep an eye on. And he denied any depressed mood. we also started to talk a little bit about other family members. He does have children who are involved but don't live with them, and we talked a little bit about advanced care planning. In subsequent visits, I did meet a daughter. I also, in subsequent visit, was able to do a cognitive assessment, a mini-cog that was normal. So again, over time, some of these assessments can happen in small bits. Before I go to the next case, are there any questions about him? You can type those in now. And if you think of any, we can come back to his case. The second case is Miss E.S., who's a 93-year-old Latina female with a history of diabetes, hypertension, and hyperlipidemia. Her chief complaint was also that she wanted to change providers. Her past medical history includes diabetes, hypertension, hyperlipidemia, and those are the medications she was on. Of note, she came into clinic with her home health aide, who was with her about 5 hours a day for 5 days a week. And she didn't bring any of her medications, but I found out that she does have a nurse who comes to her home who pours her medications for her in a Mediset. And so I spent a lot of time getting to know her social background on the first visit. She was initially from Puerto Rico and had been in New York since 1940. She graduated from high school. She had studied business. She worked as a teacher's aide and a nurse's aide in the past. She has one son who lives in Florida, and of note, a very big importance, she lives by herself. As I mentioned, she gets 5 hours of home care daily, and she does depend on Social Security benefits. She was a former smoker but denied any alcohol or drug use. And so a priority for me in this first visit was she lives alone, just trying to get to know her. And she's 93, so as I mentioned before, 50% of the prevalence for cognitive impairment is at least 50% in patients above the age of 90. And so definitely a high concern of mine. So I did a mini cog on the first visit, and this was her clock draw. And she had 2 out of 3 recall. So as you see on this paper, I actually give them a blank piece of paper and have them draw the whole thing. She drew the circle fine. She drew, and then as you could see, her number placement was abnormal and was not able to draw the hands. So this is definitely a positive screen. If you total the score, she got a 2 out of 5. So as I continue to take care of her, I also discussed a few of the other assessments on her geriatric screen. She was able to do housework and did shopping. She did need help shopping and doing housework. She did not need help showering, and she did need help managing her finances. I did not get to do the time get up and go on the first visit. She denied any weight loss, and I actually was able to review some weights. She had seen prior providers in our clinic before, and she had no weight loss. And then, as I mentioned, I did the mini cog, and then her PHQ-2 was negative. And then further visits. The second visit, she presented with a fall. We worked on simplifying her medications, and in future visits, I do plan to do a more in-depth falls assessment and vision and hearing assessment. I will say I have seen her since then, and the dementia has become more of a problem. She's actually come to clinic now with a niece who is also concerned about her care, and we did a mini mental, and she scored 17 out of 30. So we're really working on getting her more support at home, including more hours with the home health aide, getting her a life alert, simplifying her medication regimen. So those are all sort of work in progress with her. So that's that case. I'm going to pause right now because I think I have a question. Do you recommend the geriatric assessment as part of regular care, or should this be done separately? So I think this is part of regular care. I think what it should be incorporated into your visits. If one approach is that you could make a visit that's reserved just to do the geriatric assessment, so that you feel like you can do it all at once. What I'm illustrating with some of the cases is that sometimes you may do bits. If you can't do a whole visit just for a thorough geriatric assessment, that you can do prioritize what you think the highest risks are and prioritize those assessments and incorporate that into your regular visit when you're addressing the chronic conditions and other acute complaints that your patients present with. Tom, did you have anything to add to that question?
No, I think, as you mentioned, the good strategy is to try to incorporate it into the routine care and perhaps keep a checklist and go down the list, prioritize, as you mentioned, but realize that for a 20 to 30-minute visit, it's just not possible to do a complete geriatric assessment in a single sitting.
Mm-hmm. Mm-hmm. I have another question. In caring for an older adult with multiple health problems, how do you prioritize which more detailed assessments to do first if they reveal several problems during the rapid screen? So for me, I think dementia and falls are very important to address. Not to undermine the other ones, but I prioritize those if those are things that have come up in the rapid screen. Tom, do you have other things to add about?
Yeah, this is where it would be helpful to ascertain, the goals and preferences of the patient and have an honest discussion with them and perhaps the caregiver and indicate, that you've identified, problems in several areas and you want to get their input on how they might like to prioritize, those deficits. And they often come back to medications being kind of a unifying factor. Many of our patients see several subspecialty physicians and who are trying to follow guidelines and putting our older patients on a slew of medications, well attended, but often with adverse consequences. There was a nice paper several years ago by Cynthia Boyd at Johns Hopkins, kind of a prototypic older person in their late 70s, and if you followed every guideline that's out there for preventive care of cardiovascular disease and diabetes and everything else, our patients would be on 13 medications. And we know, the consequences of that approach.
Okay. Great. And so I will just wrap up with the last case, Miss E.L., 95-year-old Latina female with no medical problems who is presenting to care for the first time. She actually said she has never been to a doctor. Probably the last time was when she delivered a baby. So no significant issues that we know of. The daughter was concerned about weight loss and memory problems. So was getting, again, a better social and functional history from her. She was born in Santo Domingo. Although she'd been here for quite a while, she did graduate from high school, worked most of her life in the factory making dresses. She has 2 children, one in Virginia and one in New York. She does live in an apartment, does go up 5 flights of stairs without any difficulty. And so functionally, she ambulates with a cane, is still pretty independent on all of her ADLs. She's still able to go to a laundromat for her. And when we're talking about her IADLs, she's able to cook and clean, although she does get a little bit of help with the cleaning and shopping. And her daughter manages her finances. So functionally, seems to not have any big red flags, and she has good support with her daughter, who actually comes to see her every evening and spends the evening with her. On her geriatric review of systems, she did have weight loss, hearing loss, memory loss, and falls. So a lot to go through in the first visit. And this was her cognitive screen. Where the green arrow, the small circle, that was her initial clock draw. Once I gave her a larger circle, she was better and able to place the numbers and the time, but she had 0 out of 3 on her recall. We referred her to social work. She does have now Medicaid long-term care. She was able to get home care, home physical therapy, and also rolling walker and bedside commode for assistance at home. She had very significant cerumen impaction, multiple visits to remove the cerumen, although she still has hearing loss after the removal. And we also, at the same time, were working her up for her weight loss and cognitive impairment. Future visits would also include more depression screening and vision screening to round out her geriatric assessment. So those are the cases. I think we have a few minutes now if there's any questions about any of the cases or anything in general from the talk. Feel free to type those in.
We have a shy group.
Oh, we've got a question, actually. We have a question asking, sorry, I just lost it.
Is this the one about Medicare?
Yeah, go ahead.
Okay, so do you have any comments on a Medicare geriatric assessment visit and reimbursement? Tom, do you have any comments?
Well, a few years back, there was a new benefit for kind of the welcome to Medicare visit, which is the initial visit, in which for the first time a more comprehensive geriatric assessment could be billed and reimbursed. I don't recall offhand whether there's support for anything other than that initial welcome to Medicare visit for comprehensive geriatric assessment, and that would provide even more justification for kind of dividing up that assessment over the course of many visits and in just really embedding it within usual care.
Mm-hmm.
And there's another question, how do you approach the patient with dementia if he or she refuses care?
How do we approach the screening or
the patient?
I'm sorry, I'm not sure about the question. So how do we approach the screening of the patient who has dementia, or actually caring for the patient in general?
My impression was that it was general.
In general. Yes, that can be quite challenging because patients with dementia often don't acknowledge that they have dementia, as we mentioned in the slides. I think really, if possible, involving the family members and caregivers is a very important part of their care. And, you know, it can be very frustrating for the caregivers and family members as well, because they also are not, they're dealing with the resistance on a day-to-day basis from the patient. And so that's a very complicated question. I think obviously you are going to, as their illnesses progress, you're always going to be assessing for their decision-making capacity, their ability to care for themselves. And hopefully you don't get to the point where, you know, you actually they're not able to make their decisions, and you actually need to either conserve them or, have the family members make decisions for them, or even thinking about placement. So it's definitely very challenging because patients with dementia can have high level of functioning. They are able to leave and walk and be in the community, but often can sometimes become dangerous to themselves. So it's definitely very challenging. I think the first step is really increasing the amount of support for them at home, including home health aides or family members, and just sort of following them along as the disease progresses. I don't know if, Tom, you have other things to add.
Well, sometimes this provides us an opportunity to take a step back and what are the specific treatments that the patient with dementia is refusing. We might need to have a different mindset. Perhaps those treatments aren't as essential as they are in some of our other patients, and it's not necessarily, to have aggressive management of diabetes in this population. So if they're not taking one of the 3 diabetic meds, that might be okay. And if their blood pressure runs a little high, so be it. And really focus on, the issues that are most relevant for their own safety and based on their preferences or the preferences of the caregivers. I think that mindset often alleviates some of the concerns we have about refusal of care.
Great. And we have one last question. What was your initial workup for weight loss for the last patient discussed during the case presentation?
Yeah, so that last patient, she was, as you could tell, was not very engaged or really didn't want to come to a healthcare provider. The daughter was the one who prompted her to come. She was 95, and, as Tom alluded to, really thinking about what are your goals and matching your treatment plan and your workup to the goals of the patient. So I actually did a very basic workup, which just included some routine labs. I was not going to pursue other tests like, colonoscopy, imaging, anything like that, because that did not fit with the goals of the patient. And so her blood work actually was all fine in the end, and so we were just watching it. And then I think the other big thing to think about in your differential for weight loss is depression, and that's something we can definitely address in a non-invasive way. So that's pretty much all I did with her.
And just to follow that up, for weight loss in terms of depression, many treatments for depression can contribute to weight loss, suppressing appetite, and particularly the SSRIs. So anyone who has new onset weight loss, you want to look at the medications quite carefully. The dementia medications, Aricept and Namenda, could have pronounced GI side effects. When I'm treating an older person with depression, if I'm concerned at all about nutritional status or weight loss, I'll use an agent such as mirtazapine or Remeron, which one of the 2 main side effects is actually increases appetite and folks gain weight on it. If I'm less concerned, maybe I'll use an SSRI.
Mm-hmm. Great. Well, I think that wraps us up really nicely to the end of the webinar. So I want to thank our faculty members for your presentation. And again, for the participants, I just want to remind you that you'll need to take a post-test in order to receive the CME credit for this webinar, which will include some evaluation questions. So as soon as I close out the event, you'll be immediately directed to the post-test page on SurveyMonkey. If you're viewing the webinar without being signed into the software, you'll receive an email immediately afterwards with the same link. At any point, if you have any issues or questions accessing the post-test, you can contact me directly or your staff contact at Chicanes. So thank you very much for your participation, and we appreciate it and look forward to your feedback. Thanks, everyone.
Thank you.
Thank you.